Hello.
Yeah, Dr. Prachi.
Hello, good evening, ma'am. This is Dr. Prachi from Shield Healthcare. Thank you, ma'am. Thank you for accepting our invitation and nice to see you.
Thank you.
Ma'am, the flow is I will introduce you and Saurabh, are we launching Shield Connect too?
Okay.
Yeah, doctor, we'll be launching it.
Okay.
So, Chitrakala, you're there?
Yes, sir.
Yeah, so Chitrakala will run the AV and then she'll connect website for some 20-30 seconds and then we'll hand it over to madam.
Okay.
And will you warn me when I'm going live?
Yes, ma'am.
Yes, ma'am.
Yeah. So at the moment, I'm not live. I'm only with 3 of you. Is that right?
Chitrakala.
It says live on YouTube.
Yeah, ma'am, it's already live, I guess. But not a problem, ma'am. Not a problem. So what we do is, ma'am, generally after the webinar, no, like for example, the webinar is done. So first 3, 4, 5 minutes, no, like this part, it is automatically being edited. So the thing which is uploaded is start from the welcome and then right. So it will be foolproof, ma'am. Don't worry about it. Right now it's live.
No worries.
I understood.
You do this regularly?
Yeah, ma'am. Webinars are very much regular to us. And I know, ma'am, in the month of August only, we were like requesting you for the webinar, August and September, that time.
Very bad because already asked me so many times, and then I thought at least let me do one. And
Yeah. So we have planned and then in between that happened, no? Yeah, yeah. No problem, ma'am. So we'll have that another webinar also with you along with the doctor from UK. Yeah. So already 45 plus logins have happened, ma'am, for the program. So they'll continue, ma'am, as we proceed. Yeah, doctor, we can begin now.
Yeah, sure.
Dr. Prachi.
Yeah. Shall we begin?
Yes, please.
Okay, thank you, ma'am. So good evening, doctors. I'm Dr. Prachi from Shield Healthcare, and thank you very much for joining today's webinar. Good evening, Dr. Narmada Katakam ma'am, and thank you for accepting our invitation too for being a speaker over here. But before we begin today's webinar, let us play a short AV. And before that, I would like to introduce Dr. Narmada Katakam ma'am. Ma'am is MD Ops and Gynecology, FRCOG, PG certified ME, DFRSH, and CESR from UK. Medical Director, Genesis Fertility and Laparoscopy Center in Hyderabad. MD Ops and Gynecology from Osmania Medical College, Hyderabad. Worked in UK from 2004 to 2017. MRCOG in 2004, FRCOG in 2017, fertility training with the British Fertility Society, trainer of IMA Fertility Fellowship courses in India, and also member of FOXY, ESHRE, IAMS, RCOG, and BFS. Certified teaching faculty approved by Indian Medical Association and advanced medical specialties for fellowship in infertility courses. Speaker and panel judge in ISAR chapter. So with this, may I request Chitra for the short AV of Shield Connect. So thank you, Chitra. This is our Shield Connect a digital platform, and it has all the webinars stored, whatever webinars we had conducted till now. It has various sites, that is a lot of blogs are there, and we have also created speaker web pages, and requesting all the doctors and participants to please visit this website, and it would be very useful. So thank you, Chitra. So ma'am, may I request you to proceed with your talk of fibroids and infertility, and over to you, ma'am. Thank you very much.
Good evening all, and thank you, Shield, for arranging this webinar for myself to talk about fibroids and infertility. Is the slide clear?
Yes, ma'am.
Yeah.
Yes.
Okay. So I'm going to talk about fibroids and fertility. I'll try to cover most important the FIGO classification, because of FIGO classification, there has been consistency about what everybody talks and what the next person reads, let it be on the scan report, hysteroscopy, or laparoscopy. So I'll touch base a little bit about the classification. Then we'll discuss about fibroids and infertility. How does it affect and how can we improve? Do we do medical management? Do we do surgical management? Is it when, why, and how? Which one is suitable? And finally, I'll conclude. Fire away any questions during the slides, and we'll cover all the questions in the end. FIGO classifications. It has been almost a decade. This has been released, but I think it has been increasingly and regularly used of late in the last 2 or 3 years. If you think about, previously we used to call all 0, 1, and 2 as submucous fibroids. But 0 has bigger impact both on menstrual bleeding as well as fertility. So 0 is totally into the uterus, 1 is almost into the uterus, 2 is almost into the myometrium. All 3 are submucous. Then we have intramural, 3, 4, and 5. 3 touches the endometrium, 4 touches the serosa, 5 is in between both, but does not touch the endometrium. Then comes 6 and 7, both are subserous. 6 is partly intramural, almost all of it is subserous, but 7 is totally hanging outside the uterus with tiny pedicle, or it can be non-pedunculated as well. And 8, it can be anywhere else. It could be the broad ligament, it could be in the cervix, or it could be a parasitic. So that makes the FIGO classification. I opened up my session with this classification because there will be a lot of information running around these fibroids, because every time I say something, we have to interpret in terms of, am I talking about 0, 1, or 2? Sorry, is anyone else playing with the cursor? So fibroids, what about it? Why are we so keen about it? Because it's most common benign uterine tumor, we all know that. And almost 3/4 of the women have 1 or 2 fibroids by the age they turn 50. And how do they impact fertility? If you scan 100 infertile women, at least 5 to 10% of them have infertility. And Bate et al. Did a big study in 2003, and what they identify is, it's not an incidental finding, but 2.4% of couples, fibroids are the exclusive cause of infertility. It is a big number if you take 2.4% of all the millions of couples. How does it cause infertility? There are 9 different mechanisms. It is quite important to know, for us to know the mechanisms, because each different kind of fibroids, depending on the location and the size, they do have a different role to play. And sometimes we can see that this fibroid might be having a role in 3 or 4 or more than 5 different ways how it can cause infertility. Obstruction is one, where their mere physical presence can cause an obstruction, probably just sitting on the top of the internal os, and can cause blockage of the sperm to go. Mechanical, by huge presence and distorting the endometrial cavity. Transportation, I'll show in one of the videos in later slides. There can be very, very tiny fibroids at the at the ostia on the inside, which can cause impediment of transport of the sperm from the uterus and egg from the tube. Implantation. There are various ways how it can cause implantation impedance. One of them is uterine contractions hindering the implantation. That's usually after IUI or embryo transfer. Inflammation, that's a little less, but there can be a chronic inflammatory response by the underlying endometrium. It could be because of friction between 2 walls, or because it could be because of long-standing presence. The other 4 mechanisms include peristalsis. Because of the presence, they can cause increased peristalsis of especially the intramural fibroids. This was done by some studies by Yoshni et al. And what they found is, when there are high frequency peristalsis found, they didn't find any woman getting pregnant after IUIs. But if there was a low peristalsis, 1/3 of them achieved pregnancy. So the peristalsis is quite important. And whoever is practicing IUIs, obviously, embryo transfer is different level of game. But if somebody is doing IUIs, try to minimize the contractions so that there is no peristalsis and there is no result of no pregnancy. Thin endometrium over fibroid might not always be the case, but if you do your own scans, check how thick the endometrium is over the fibroid, especially if they're fundal. That's where most of the implantations happen. If the endometrium is thin, obviously there is poorer blood supply to the embryo, and then that disrupts the flow, and that can result in no pregnancy. It also does affect early embryonic development, especially the submucous fibroids. We have read in the past that cytokines, glycodyline, and interleukin are very, very essential for implantation. But the presence of submucous fibroids reduce the levels of these. And because there's reduced support to the implantation, then there is no pregnancy. Finally, is the endometrial receptivity. Complex names, HOX and LIF, as well as beta-3 integrin. Beta-3 integrin we do hear more often. They are reduced throughout the endometrium. Therefore, the receptivity is reduced. So these are the various ways how a fibroid can cause reduced implantation, reduced receptivity, and also increased miscarriage. How do we diagnose? I'm sure I don't need to tell you at all, but I'll play some slides. So this is trans-abdominal scan, full bladder. There's something filling the whole cavity, possibly fibroid. Maybe if I put a Doppler, I might see some blood supply, or I can infuse some saline into the uterine cavity, and I can nicely differentiate that there is a submucous fibroid, wide base, filling almost whole cavity. Or I can use a hysteroscope, directly see with the naked eyes what it is and where it is. And there's another way of seeing just by 3D scan. You can see small fibroids, which are submucous. So abdominal scan, vaginal scan, 3D scan, infusion sonography, and hysteroscopy. And obviously, if they're bigger and multiple, you go for MRI. Then the confusion is about, is it a solitary adenomyoma or a fibroid? Diagnosis is important because adenomyosis causes infertility in different mechanisms, and fibroid causes different mechanisms. And if you think about doing a myomectomy or fibroid excision, it's much easier because it's bound in a space. But if it is adenomyoma, you will be hitting yourself thinking, oh my God, why did I not diagnose properly? In the 3D scan, you can see there is a space occupying lesion here. Otherwise, it could have been a nice normal triangle. If it's a fibroid, you can see a skirting vessel. That's what you would see if you do an open myomectomy or a laparoscopic myomectomy. The fibroid, you can see blood vessel only at the periphery and none in the substance. But if it's solitary adenomyoma, you can see blood supply throughout the substance. So you can remember this very well, a skirting blood vessel in a fibroid and diffuse blood supply when it is adenomyoma. And to be precise, the difference is adenomyoma is not very well circumscribed, but fibroid is concentric or rounded. Adenomyoma has ill-defined margins, but fibroid has well-defined margins. Fibroid may have some calcifications, but adenomyoma will never have a calcification. And when you do a color Doppler, as you've seen here, there's intramural lesional and translesional vascularity, but in the fibroid, there's peripheral skirting vessels. How does fibroid influence infertility? Will every single fibroid have same effect, or does it vary? There are 5 different ways how a fibroid can cause more difficulty in getting pregnancy or less difficulty. And the 5 include site, distortion of the cavity, size of the fibroid, number of fibroids, and distance. What could be the distance? The distance is from the peripheral border of the fibroid to the endomyometrial junction. Let's see what is the evidence for these. If you talk about sites, submucous fibroid is the worst because it's in the cavity. It could be where the implantation is, and it has direct effect on impending all the factors, and that causes least fertility. On the other hand, subserous fibroid has the least impact because it's totally outside the cavity, and it may not even cause some peristalsis. Intramural, it depends on it is 3, 4, or 5, and it's big or small, and how far it is from the junction, and is it causing any distortion. And this is from the paper from Sunkara et al. In 2010. If you look at this 3D scan, there's one fibroid there, there's one fibroid there, and if I see as a rotation, there were another 2 fibroids. This lady, she had 2 laparoscopic excisions of endometriomas and 2 submucous fibroid resections. And by the time she came to us, she already had 2 IVF failures. IVF and 2 IVFs and 3 embryo transfers. Not an easy case. And then what happened? We found these fibroids. And by the time we did one cycle, these fibroids grew enormous and they almost started distorting the cavity. Those were the days when ulipristal was available. So we didn't want to venture another submucous fibroid resection, because every time you do that, you might be damaging some endometrium. So we just gave her ulipristal, allowed it to shrink, and she took another 2 cycles before she got pregnant. And that was a big sigh of relief. And the baby is almost 6 months old now. So that was one of the complex cases. The reason I'm mentioning that case is it's very important to decide to operate or not to operate. The more number of times you operate on the submucous fibroids, if it's pedunculated, there is tiny stalk, and to cut up the stalk, you're not doing anything to the endometrium. But if you're operating on the fibroids, which are having broad base, every time you remove the broad base, you don't know how much depth of the endometrium you are going to damage. And every time there is a scar, probably that will be bad site or poor site for implantation. So that's about the site. Submucous, burst for pregnancy, subserous, best for the pregnancy. So the intramural, Sunkara et al., what they studied is they found 9% pregnancy rate when the fibroid distorted the cavity, but 34% when there was no distortion. 34% is very close to what's normal. I keep talking about distortion. What is distortion? So this is almost a 5 centimeter fibroid. So this lady had had a deep septum, 2 IVF failures, and two frozen embryo transfers, and then she came to us for treatment. So we noted that there is a 4 to 5 centimeter submucous fibroid. Now my question is, I know the film is not the best, but is there a distortion of the cavity? Where is the endometrial cavity? So that's what is the endometrial cavity. So is it distorting? Definitely distorting. So that's the uterus. And that's the endometrium. Ideally, it should have gone like that. So it's distorting. So we did a myomectomy, septal resection, and then embryo transfer. After 2 cycles, she conceived and has delivered the baby. So the systematic review, this is from Fertility Sterility in 2009. What it says, a lot of papers give similar results. Probably the successful pregnancy rate and ongoing pregnancy rate is slightly different. What they say, along with others, submucous fibroid outcomes are decreased. Removal seems to confer benefit. Intramural reduces fertility. Results of therapy are unclear. Probably it's based on the size and the numbers. Subserous does not affect, and removal does not confer benefit. So just leave them alone. This is another paper published in Gynecological Endocrinology, 2006. What they studied is the pregnancy rate before myomectomy. So they took 2 cohorts, and one group had no myomectomy and other group was post-myomectomy. Definitely post-myomectomy had increased pregnancy rate in different grades of fibroids, irrespective of submucous or intramural. Grade 2, we all agree it is submucous, and intramural, this is grade 5. Then there was another paper in BMJ in 2009, checking if removing will increase the fertility. So this was a systemic review of 22 observational studies and 1 randomized control trial. They obviously confirmed that there was reduced fertility in women with fibroids from across all the papers. And they did say location of the fibroids matter. Subserous, no difference. Submucous, with or without intramural, they studied the combination. They confirmed that there's decreased fertility, increased pregnancy loss. So that was the site and distortion. Now coming to the size. What size is acceptable? Probably if it's submucous, no size is acceptable. But if it's intramural, what they found is if the fibroid is more than 4 centimeters, they recommend removal. If you look at this, there's a long cervix and there's a fibroid here. So this is all a solitary fibroid. You can see how close it is into the endomyometrial junction. So the cavity is ending here and the fibroid is starting there. There's barely any space, and the fibroid size is definitely more than 4. So if she comes for IVF, I would definitely recommend removal, followed by infertility treatment by embryo transfer. Increased number of cycles are needed to obtain an ongoing pregnancy if the fibroid is 4 centimeters and you do not operate, but go ahead. So that was the size. And now coming to the number. Guess a number above which the pregnancy rate might be reduced. I can't see your questions, but you can feel free to type in the chat box and we can revisit at the end of the session. More than how many fibroids will cause increased infertility rate or reduced ongoing pregnancy rate? The number is 3. Felicini et al. In 2003, they had published a paper where if there were less than 3 fibroids, the pregnancy rate was 37%, but if it was more, pregnancy rate was 28%. And in the controls who didn't have any fibroids, pregnancy rate was 41%. So there should not be any distortion. Size should be less than 4 centimeters. Number should be less than 3. Ideally subserous. So those are all the factors we all need to remember every time we read a scan and somebody comes for infertility. Now coming to the distance of the peripheral border of the fibroid with the endomyometrial junction. Abulgaf et al. In 2004, what they found, if the distance is more than 5 millimeters, there's no effect. You can see this is 4.9. When you see a 4.9, I definitely think, damn, I wish there was Ulipristal available to give for a month, but GnRH analog also will work reasonably effectively for the intramural ones. So probably give a shot of GnRH analog, let it reduce, and then take the next cycle. This is another fibroid. You can see the endometrium is ending there, the peripheral border of the fibroid is here, and the distance between them is 0.95. I wouldn't do anything with her because there's only one fibroid, and it was around 3.3 or 3.4 centimeters, and the distance is more than 5 millimeters. So it's just making a wise decision when to touch them, when to leave them. What does Cochrane say? In February 2019, Cochrane reviewed 4 studies. Total participants were 442. But all studies had not clear inclusion or exclusion criteria. So they concluded that evidence is of very low quality and they cannot be considered conclusive. So we still need to publish some individual papers for them to do a review to say, but most papers did confer mucous fibroids reduce the fertility. Effect of fibroid on ART, everything what we discussed in the first 2 slides of 9 steps, and specifically to ART, they alter the endometrial receptivity and obviously they negatively affect the implantation. And what they found is submucous fibroid has odds ratio of 0.3 for implantation, which means only 3 out of 10 will get pregnant, and out of those, only 3 out of 10 will get delivered. Intramural, it's almost double the chance. 6 out of 10 will have implantation, and 7 out of 10 out of those 6 will deliver. So again, submucous is the worst. So how do we treat? You all know how do we treat, but I'll just recap quickly. Expected management, do nothing if it's not causing a problem. Fibroids, treat them only if they're causing a problem. Do not treat the fibroid, treat the symptoms. If there's heavy bleeding, treat heavy bleeding. If there's infertility and if they're in the uterine cavity, remove them. But otherwise, if they're causing some pressure symptoms, remove them. Otherwise, just acknowledge that they're there, but do not touch them. Medical managements include tranexamic acid, hormonal include contraceptive pills, Mirena, norethistone. SPRMs were greatly used until a few months ago, and obviously GnRH analog injections. Surgical uterine artery embolization, laparoscopic or open myomectomy, hysteroscopic resection, hysterectomy. A little more touch base on hysteroscopic resection and only rest of them, especially hysterectomy. It's not my role to talk in this talk because we're talking about fibroids and retaining the fertility. Medical management. Jacques Doniz, I don't know if you heard the name, the man from Belgium, was very big in terms of medical management of fibroids, and he did long-standing studies, Pearl 1, 2, 3, on use of Ulipristal on its own or with GnRH analogs, and he published long-standing papers, and unfortunately it has only been out of market for the last few months. Otherwise, they said it should be the first line of approach for medical therapy. So about the medical management, what all do we know already? Just type what all medical management you know, which we can use in fibroids. If I say, I'll tell you 10, keep typing how many ever you know. I'll give you a few seconds and I'll display the list. We all use them regularly in different scenarios. It's just putting everything in list. It just makes the slide. I'll go ahead. OC pills, oral or injectable progesterone, letrozole, danazol, gestrinone, antiprogesterone, selective estrogen receptor modulator, and GnRH analogs, antagonist, and analogs, progesterone myrina, and then SPRM, selective progesterone receptor modulator. Everything is there. Danazol is not recommended anymore, and SPRM's ulipristal is not recommended anymore. Rest of them are still hit and miss being used. Mifepristone was also one of the cheaper versions with less effectiveness than ulipristal, but it was also good. Still there. Just briefly touching how GnRH analogs act. They inhibit the gonadal axis, hypothalamus, pituitary. No FSH, no LH, therefore there's no estrogen from the ovary, and they cause state of hypoestrogenism, leading to consequent hypogonadism. FSH, LH are continuing to be low, so there's no feeding for the fibroid and it gradually shrinks. This is a study where they gave 3.75 milligrams per month of GnRH analog, and they did a study. So first scan was done, then the injections were given, and the scan was done after 3 months and 6 months. What did they find? They found that there's a 36% reduction at the end of 3 months and 45% reduction end of the 6 months following GnRH analog on a monthly basis. And this is from meta-analysis of 14 trials, which is reasonably strong study. And what they found is that the uterine and the fibroid volumes are reduced, surgery was easy, hospitalization time was less, and they also noticed that an abdominal surgery was converted into vaginal surgery, or a midline incision was converted into a transverse incision. That's reasonably beneficial for the women. And these are all the studies from 91 and 2002. Little more about analogs. The only downside of using GnRH analog before you contemplate myomectomy is sometimes you may lose the planes. There can be difficulty in enucleation, and the smaller ones shrink and become micro-sized, and they might rebound and grow later, and then you might see few more small fibroids. But anyway, it takes a little longer time for them to become 3 or 4 centimeters and then distort the cavity. So at least initial job is done. SPRMs, I have not much to talk about this because it has no role now, but the other drugs we can use are mifepristone. Ulipristal we can't use. Telepristone, I haven't seen it available here. And this, you can see it is from donazetol. All reduce the size of the fibroid and heavy menstrual bleeding in a dose-dependent manner. It was only ulipristal acetate which had a sustained effect even after 6 months and 12 months, but which is off the market now. And how does it act? It stops the uterine bleeding. It results in benign reversible changes, but it also acts on pituitary by direct action, amenorrhea, inhibiting ovulation by hypogonadism basically. And on fibroids, what does it cause? It reduces size by inhibition of cell proliferation and induction of apoptosis. If you take GnRH analog, it just acts on pituitary, but if you take SPRM, it also acts on endometrium as well as the fibroids. So what are the surgical and non-surgical managements? Hysterectomy is the last option I'm going to talk about. MRG focused ultrasound, uterine artery embolization. This I've seen only once. Vaginal occlusion of uterine arteries. Hysteroscopic myomectomy, I'll go in little detail about this, and laparoscopic myomectomy. They can be there anywhere. I'm not going to mention anything about hysterectomy, just a little bit of discussion about the rest of them. MR guided focused ultrasound surgery. Outcomes are enhanced by GnRH analog pre-treatment like any other surgery like myomectomy. Mean time to conception was 8 months after the procedure, and those who had MRG first, 41% of them had live birth. However, 28% of them had spontaneous abortion, and 2 cases had placenta previa. Probably the placenta was on, I don't think there's a link. So this was studied by Rabinovici et al. Uterine artery embolization, long-term effects have not been established yet, is not the first line option because it's transient and permanent amenorrhea. Somebody comes to you for infertility and you advise uterine artery embolization. If they have permanent amenorrhea, then it will make it difficult to do fertility treatment. The incidence of amenorrhea is less than 5%, so you can always tell them there's a risk of less than 5%. Do you want to go ahead or not? But this is more common if the treatment is done close to menopause, not in somebody who's 25 or 30. Coming to the surgical management, I'm not going to touch on laparoscopic management, probably because it has a role if the fibroid is large. It has a role when the fibroid is many, but I just focused on the hysteroscopy for now. Hysteroscopy, you all know, it's looking inside the uterus. Greek word, hystero means uterus, scopy is looking. It can be diagnostic or therapeutic. Diagnostic, you just in and out, you see and tell what it is. But therapeutic, you remove whatever you see. So you have 0 degrees and 30 degrees both available. When do we do hysteroscopy? There are a lot of indications why we do hysteroscopy. About the fibroids, it's grade 0 and 1. You can remove the septum, you can remove the adhesions or polyps, you can do endometrial ablation, fallopian tube catheterization, hysteroscopic sterilization, and any IUCD removal. I'll just focus on the submucous fibroid, grade 0 and 1. Contraindications, make sure there's no active uterine infection. Do not forget to do a speculum before you list them for surgery. Systemic, severe systemic illness, uncontrolled diabetes or hypertension, they might not sustain the anesthesia. If they're already pregnant, obviously the purpose of doing it is pregnancy, so don't do it. If there's heavy uterine bleeding specifically, I'm mentioning the word heavy because your visibility is impaired. If it is only light, probably you can wash off and then see, but if it is heavy, it will be difficult. And cervical cancer or endometrial cancer. Those are the contraindications. Why should you do a hysteroscopy? Because it's a gold standard in evaluating cavity. You can, if you're very good at scan, you can pick up, but it's not equal to seeing with your naked eyes. It allows the direct visualization of the uterine cavity, and when you see, you remove as well. You may remove completely if you have right expertise and right equipment in your hand. And there's an opportunity for targeted biopsy. That reminds me of one of our studies when I was in UK. There were blind biopsies done in postmenopausal bleeding, and there were targeted biopsies done under hysteroscopic guidance. 1/3 of the women with blind biopsies came back with recurring postmenopausal bleeding. None of them came back after hysteroscopy, hysteroscopic guided targeted biopsy and removal of any polyp. But interestingly, we also found that 8% of them had endometrial cancer at the base of the polyp. So targeted biopsy under vision is always the best in postmenopausal women. And I should again come back to infertility now. It's safe and efficient. It's the smallest operative procedure in all gynecology. Can be performed on an outpatient or a daycare basis. Complication rate is very low unless you really goof it up. Very low incidence of life-threatening complication, especially with the diagnosis. Like perforation of the uterus, not realizing you've already damaged the uterus and then going into peripheral bowel or bladder. That's quite rare. So how do we do hysteroscopy? Most important is careful selection of the patient. Detailed medical history to see the contraindications and fitness for surgery, clinical assessment and ultrasound guidance, bimanual examination. Sometimes you do the bimanual examination, you know that the uterus is fixed or retroverted. You'll definitely prevent a perforation when you do that, and definitely exclude pregnancy by let it be urinary pregnancy test or the ultrasound or beta HCG. Those are very important before the surgery. Informed consent and written consent, explaining the procedure, not being able to complete the procedure, having any complications, including damage to the bowel and bladder. Endometrial preparation. Why is it necessary? Because when the endometrium is thick and you put a scope, you feel like you are in those Telugu movies where there are white saris floating here and there. It's very hard because the endometrial flakes are obstructing the camera view. That's why endometrial preparation is very, very important. You want the endometrium to be thin and no heavy menstrual bleeding. Why should you do that? It reduces the thickness, it reduces the endometrial debris, it reduces the vascularity, it reduces the operating time, and it also reduces the fluid absorption time because the fluid absorption happens when there are open blood vessels, and this can reduce by all means. And how do you do endometrial preparation? Just put them on pill, oral contraceptive pill. Equipment, very similar to laparoscopy, minus insufflator. Light source, light leads, video camera, monitor. Distension media. This is something very important. Uterine cavity is virtual until distended. It's always collapsed. You need to fill it with something to open it up. I've also heard about CO2. I didn't mention because I've never seen anybody using or recommending. Definitely saline and glycine. What was used in the initial days until last few years? Glycine. Glycine was used and monopolar energy was used in the past. Presently, a lot of them are recommended and used saline and bipolar energy, where the fluid absorption complications and the damage is much less. So you can see you do in the lithotomy position, there's a bladder, there's uterus and rectum, and it is visualization of the uterus. Distension technique, you can do various methods. If you have a fluid management system, that's fantastic. But if you don't have, you can raise the rod of the IV set and keep at least 1 meter above, or you can use the BP cuff and then inflate the cuff. Or if you're fortunate enough to have a fluid management system, make sure there's a continuous flow of the saline into the uterine cavity, and that gives beautiful, constant, clear view. And try to maintain 70 millimeter of pressure. That gives enough distension. But probably if you're operating or there is a leak, you might need to increase it to 80 to 120 millimeters pressure. But if you are operating in the outpatients, try not to go beyond this, because there are two things which cause pain to the women during hysteroscopy. One is distension. Two is touching the fundus with the instrument, fundus or lateral walls. As long as you're within the cavity, they do not wince about pain or anything. But as soon as you touch the lateral walls or the fundus, they can feel the pain. And obviously, if you distend as well, then will be touch and distension that may make them stop you do the procedure. Operative hysteroscopy, there are three levels. Level 1 is just seeing what is there. Diagnostic hysteroscopy, maybe you take a biopsy, you remove small polyps and you remove an IUCD. Level 2 is fallopian tube catheterization, any minor assurements and removal of a grade 0 fibroid or a large polyp. Level 3 is a different level. You may resect the septum. It can be major assurement syndrome. You try to divide and clear the whole cavity. Endometrial resection or ablation, resection of type 1 or type 2. Type 1 is more into the cavity, a little bit into the myometrium. Type 2, reverse, a little bit into the cavity and most of it into the myometrium. And then repeat endometrial ablation or resection. This is little tricky because there's already myometrium shaved off, and if you don't carefully do, you may perforate. Methods of myomectomy depends on where it is. If it's a fibroid prolapse through the cervix, you may just cut the stalk after applying a clamp, or you may use bipolar or monopolar electrocautery and use a resectoscope. I'll show a small video. These are all newer methods of VersaPoint, which is by bipolar energy, and MyoSure and TrueClear. They're all mechanical. There's no energy needed. They're mechanical and quite safe and quite fascinating to watch. So what's more important for the successful management? The 3 Ps. One is patient selection, one is preparation, and the practice. So hysteroscopic myomectomy is offered for 0, 1, and 2. Heard about step W? That's very important to understand which fibroids are operable. Are they operable in one sitting, or will you need 2 sittings or any other treatment? Step W is an acronym for each letter means a word. I'll go through. S is size. There are 3 sizes: less than 2 centimeters, 2 to 5 centimeters, and more than 5 centimeters. Depending on the size, you grade them 0, 1, 2. After 5 slides, I'll show you why it is important and how it helps you in counseling the patient. So first one is size: 2, less than 2, 2 to 5, more than 5. ST, T for topography, are the inferior, at the middle, or at the fundal, which is upper. Guess which one is easiest to treat? Obviously 0. So that's why it scores 0. Extension of the base. If you take the horizontal view, see how much surface of the uterine wall they're occupying. Is it less than 1/3, 1/3 to 2/3, 2/3 to 1/3? This is important because if this fibroid is just hanging with a stalk, you only need to dissect the stalk. But if it's such a wide base, you have to dissect this wide base. 1, technically it's difficult. 2, You also need to bear in mind to tell the patient that you will be touching this much surface of the left lateral wall, and that can also result in reduced implantation on the operative site. So that's extension. P is penetration. How deep is it into the myometrium? So grade 0, grade 1, grade 2, that's easy. More than 50% in the cavity or less than 50%. These are all by Lasmer and Borozzo, and they have been published in 2005. And everybody who operates on submucous fibroids, I kind of strongly believe that they'll definitely use this classification for preparation of themselves as well as the patient. So you put STEP, and if it is on the lateral wall, you add one more score, and everything easiest has 0, medium has 1, and the most complex has a score of 2, and you add up the score. If you think about most complex, very big, fundal, quite wide, and it is deep into the myometrium, and that will score 9. And you have to consider alternatives to the hysteroscopic technique. That's why it's important. Rather than jumping and doing a hysteroscopy and saying, I'm sorry, I removed only part of it, it's easier to be mentally prepared. So if you think about this, so the size, this was 2.5, so scores 1. It's upper, so scores 2, 1 plus 2, 3. It's almost occupying more than 1/3, so another 1, that is 4. And penetration is totally 0, and definitely it's on the lateral wall. The score is 5. So it's not easy. You might either consider GNRH analog or tell them I might be able to remove part of it and you may need a second sitting. So this is the mechanical hysteroscopic morcellator. So you have a scope, you just pass into the uterus and you wait for the distension. Once the cavity is distended, you can see better. And then you remove the introducer and then insert. This is the MyoSure handheld device. And then you see there is a blade on one side. The black line is a blade. And you shave the whole polyp or the fibroid like you're applying cheese on the bread. So that's the blade. And you just nicely, gently excise the whole polyp or fibroid, wherever it is. Because and you can see the end result. And because the frontal edge is blunt, there is very less risk of perforation. I'm going to show you a live case rather than a demo. You can see there is a polyp. What they found, Dorez et al., one of the studies, they said post-surgery pregnancy rate ranged from 16.7 to 76.9 with a mean of 45%, which is reasonably good. So you can see that's the, you'll be still thinking, is it pedunculated or not? So you just apply. That's quite quickly disappears if it's a polyp because it's very soft. Once you press the pedal, the blade rotates. And initially, when I did the first look hysteroscopy, it looked like one polyp, but you can see at the end of it, that's the polyp at the ostia, and you can agree, you will definitely agree that it will cause mechanical blockage. And there's another one where you can see a fibroid on the posterior wall. It's around 1.5 centimeters. That's a mechanical blade. And once you approximate it and press the pedal, it just morcellates and it just disappears in 20 seconds time. And so clean, so bloodless. Now this is the resectoscope, which was traditionally used and which is what is most commonly available here. There's a short chip method and a long chip method. You can see the loop dissecting. So this is the nice globular submucous fibroid. You can see the loop coming out and taking a chunk of material. So that was monopolar diathermy used to get the chunk of the fibroid. So you take piece by piece until you see the base. The only thing you have to remember is you are not advancing the loop until you see, unless you see where you are. Otherwise, without realizing, you may end up easily damaging the myometrium. So that's what you have to see and carefully scoop fibroid in layers. Troubleshooting, once you start doing, you know that there can be troubleshooting with the display, distension, debris, especially when you're doing the resection, inefficient cutting if the diathermy level is not enough. A view can be difficult if there's any blood. Even one drop of blood can make the whole field messy. There can be a leak if there's excessive cervical dilatation and hemorrhage if you approach any bleeder. Complications are very rare, as I mentioned, especially in the diagnostic one. Failed procedure can happen, but it is less than 2% of the cases. This you can consider equal to any of your failed DNCs and failed IUIs. What do you do? Same thing you do with hysteroscopy, the cervical dilatation. There can be gas bubbles interfering in view. There can be problems due to distension media, but with the normal saline, it's very less because it's isotonic and a woman can tolerate at least up to 1.5 to 2 liters. If you do not do your procedure carefully, there can be infection, there can be bleeding or damage and perforation, which is, I would say, totally avoidable and sometimes an aesthetic problem. The serious complications are very, very rare, like 12 in 1,000. Conclusions? All fibroids do not need treatment. All fibroids do not affect fertility. Those which affect fertility include submucous fibroids, more than 4 centimeters, less than 5 millimeters from the endomyometrial junction, more than 3 in number, and if they distort the cavity. Rest of them, just acknowledge their presence and do not touch. Where necessary, myomectomy is a better choice for increasing the infertility success rate in comparison with the medical management. If it is 0, definitely myomectomy. If it is 1, less than 3 centimeters, hysteroscopic resection, more than 3 centimeters or anemia, give medical therapy, improve their health status. And if there's don't need, no further treatment. If they still need, hysteroscopic myomectomy. Conclusions. Treatment selection will also be dictated by location, size, and number of fibroids, what's available, are they recurrent, what is affordable, what's the personal experience and the comfort zone of the operator. Wisely choose who needs what and when. Thank you.
Thank you, ma'am. Thank you very much. It was a very beautiful presentation, especially the surgical management aspect, the kind of algorithm you have presented. I'm sure it would be very, very useful to the clinicians, to the doctors. So thank you very much. And if there are any questions, of course, I will read out to those questions to you. Chitra, Saurabh, any questions? Ma'am, as far as the fibroids are concerned, recurrence is also noticed in few patients. So how common it is, the recurrence, and what impact it has on the treatment? Like how the treatment is decided if the recurrence is there?
So one is recurrence, one is impact of recurrence on the treatment. Correct. Recurrence can happen by 2 means. One, we've used GnRH analogs, they shrunk and there is a rebound growth. The second way it can happen is you have not removed them in total and then they regrow where they are. Correct. So every time you remove a fibroid, you always tell them, if you're confident that you've removed completely, this has been removed. If another one comes, it can be a new one or it could be something very small which I couldn't see. That initial bit of counseling and explanation to the patient is very important. The next one is impact of this recurrent fibroids. Again, it will impact if it is submucous, it will impact if it is larger than 4 centimeters. Probably it will take ages of one small fibroid to become 4 centimeters. Otherwise, the biggest concern is repeated endometrial injury or damage done because of the surgery. If you repeatedly do the surgery for the same fibroid rather than removing it in one go. So wisely remove the whole fibroid and definitely counsel the patients about recurrence of not the one you have removed but a different fibroid.
Right. So, ma'am, repeated surgeries is okay to do it. I mean, if the conditions are not bad. So that's the take home.
I would say try to do completely so that you don't need to do a recurrent surgery.
Okay.
But if it's a recurrent fibroid, obviously, if it impacts fertility, then you operate with least and minimal damage to the uterus. Okay. But I wouldn't recommend repeated surgery.
Okay. Ma'am, in the literature, there is also mention of a uterine artery embolization. So how effective it is and is it done regularly? So your thoughts and guidance.
It's more commonly recommended for heavy menstrual bleeding in perimenopausal age women. It won't work for pressure symptoms, definitely. And for infertility, as I mentioned in one of the slides, the biggest concern is amenorrhea in 5% of the women, and then return of periods may take a little longer. So if they're already at the edge of past 30, then you might be losing a little more time to get them back to the regular endometrial formation phase. That's not definitely a first choice for treatment.
Right. Thank you, ma'am. And the literature also mentions about myomectomy during pregnancy. So is it done, or what is your thoughts again?
One single line: do not touch anything in pregnancy
Okay.
apart from the uterus to deliver the baby. It's highly vascular. What was 7 centimeters will become a 35 centimeter uterus. Vascular supply is more than 10 times. You will be regretting for your life if you touch the fibroid.
Okay.
Especially any of them like intramural.
Ma'am, Dr. Sri Chandana has mentioned that it is an exciting presentation, and Ma'am was very happy to learn about the topic. There are beautiful comments, so many comments are there from the doctors that the topic was excellent.
Thank you.
Ma'am, I don't see any additional questions, so we can close this webinar now. So thank you again. Thank you very much for the time spent with us, accepting our invitation, and for that beautiful presentation. Thank you, ma'am. Thank you very much.
Thank you, everyone, for spending pre-festival time on the session. Thank you, and have a happy Sankranti. Thank you.
Yeah, wish you the same, ma'am. Thank you very much.
Thanks.
Thank you, doctor. Thank you very much. Happy Sankranti to you and all. Thank you very much.
Thank you.
Thank you, participants, and wish you a very happy Makar Sankranti.